That's right. Thank you,
Okay.
Chair. Just two issues that I want to pursue before offering the call to my coalition colleague, Senator Davey. Ms Edwards, thank you for your answers to Senator Watt and Senator Di Natale about the app, and particularly about the privacy protections in there. They're very understandable questions that I think a lot of Australians have and want to be reassured about. If and when they are reassured about, hopeful they will download it in big numbers. One thing that we haven't really covered today is the purpose of the app. So could you outline for us the rationale of what the app can assist us to do?
The purpose of the app is, there's solely one purpose of it, and that's to collect information about close contacts of people who have been in contact with somebody who's diagnosed with COVID, so that state and territory health officials can include that information in the work they already do to find, track down, advise and work with people who may have been close contacts. And that's a fundamental part of stopping the spread of the virus, is to make sure we find anybody who may have been in contact and ensure they self-isolate, get treatment that they needed, get tested and so on. They already do that. It's absolutely a major thing that's happening now, and all states and territories have dramatically ramped up their capacity to do this. But at the moment, it's a very manual process. So if I'm diagnosed with the virus, I'll be able to tell them about the family that I've been with. I might also be telling them about some people that I've been to when I've been in the office on those days I'm not working from home. But also I'll be saying, well, I went to Woolworths and I think I was more than 1.5 metres away in the queue, but I'm not sure, but I don't know who those people were. As the system currently works, state and territory governments can look at CCT footage to try and figure out who people are potentially. They do all sorts of very fantastic investigative work, and they also put out alerts. Were you in Woolworths at Dixon on this date? What the app will allow us to do is to really add to that process, so that if I was in the line only a metre away from somebody for 15 minutes, a long line, that we will in an encrypted form have swapped unique identifiers with, once I'm diagnosed with COVID, I put into a code into my phone, and all of those unique identifiers that I've swapped go into a central depository, which can be accessed, again, only by the public health official. The public health official will then be able to pull up a whole stack of phone numbers, which is the first time it's de-encrypted into phone numbers, and be able to call up Senator Paterson. I think you might have been in contact with somebody. We need to talk to you about it and make sure that you've got the health needs you need, plus be tested or isolated as appropriate. And the key thing is that's the only purpose of the app, and we've designed the functionality very carefully, so only the functions required to do that purpose are included and no others.
Thank you. So obviously there what you're saying is one of the advantages is in the current manual process, as I'm being interviewed by a contact tracer, I won't know the names, let alone the phone numbers of people that I've had incidental contact with in the community, as you say, in a line at the supermarket, but also perhaps on public transport. There's no way I could provide that information, and this app will allow that. I'm also interested though, does it make any difference to the time taken to complete this contact tracing, and is that of assistance? So for example, how long does the manual process take right now?
I'm not an expert in the manual process, but it can take a long time, and a lot of those processes, the interview can take a long time. The person who's infected might be very sick and not able to do the interview as quickly as possible. As I say, if it's in the supermarket and so on, and you have to go to other sort of mechanisms. So having the phone numbers will be an enormous assistance. If there's a large take-up of the app, then that will in some ways replace a lot of the work that has to be done, because you can go straight to the phone numbers. It won't entirely replace it. We rely on these very skilled people already to do these fantastic investigations that they do, but it certainly has the scope to greatly, I think the term's been used, to industrialise our contact tracing process. And we think that's an absolutely fundamental part of our health response, which is why we've been working on the app.
So would it be fair to say that the current manual process can take on average a couple of days to complete after a positive diagnosis?
It can take longer than that, I would think, and it will be incomplete is the other concern, and perhaps it'll be incomplete whatever we do when we're in a community and out and about, but this will certainly be an enormous tool to help. So it's really just to make that process better.
So compared to this kind of process that goes for a number of days, a technological process with an app could be instantaneous?
For those people for whom you've had a digital handshake, yes.
Yeah. Okay, great. And obviously, I share the concerns that many people do about those privacy protections, and I'm reassured in part by the answers you've given about the robust protections that must be put in place to assure that. But moving on to the second issue, yourself and Professor Murphy answered some questions about the increase in ICU bed capacity asked by my colleague Senator Davey earlier. But just to drill down a bit more specifically on that, what about the increase in ventilator storage and capacity? Because I know that's slightly distinct from ICU capacity generally.
There's a few things been happening in relation to ventilators. First, a lot of work been done with the states and territories, both through the AHPPC, but also with CEOs of health departments, which I'm involved in, to make sure we know exactly what's out there in current ICU. Also what's out there not in current ICU, like some anaesthetic machines that can be added in with minor changes. Also things like finding what ventilators there might be in the community for all sorts of reasons. We've even gone so far as to talk to the Veterinary Association about whether there's any human ventilators there which could be appropriately cleaned and unused. So that's one side of the process. In addition to that, we've been aggressively procuring ventilators, and we've been doing that in two ways. One, going to overseas locations, but very importantly in Australia using local production, and that's both using an existing world-class production facility in Australia, but also actually investing in local industry to get up a rapid work to create a ventilator here in Australia, and we've contracted with a party in order to do that, a consortium. That work we're doing very closely with the Department of Industry, who are also working with other industries to upscale our ability to produce PPE and other items. But the ventilator work is a key one, and we're really happy that we now have on order, we think, sufficient ventilators to enable us to meet that 7,500 aim and a bit more. We're being cautious.
Great. So just to kind of put that in direct number terms, where have we gone from? How many did we have, and how many do we expect to have?
I think Professor Murphy said we had something like 2,400 ventilators in ICU rooms at the moment. Then we've found through various mechanisms about 2,000 more, and then the balance we're buying. But as I say, and a few more, because we've been very cautious. Obviously the scenes we've all seen on TV and so on in other countries are just beyond. The other thing about ventilators is working very closely with states and territories about how we make this a national resource. We've expanded the national stockpile, at least notionally, to say it can have ventilators in it so that we can make sure that they get to go where they're needed, when they're needed, and all states and territories have been very cooperative in that work. Great.
So just one final question from me. We've gone from 2,500 roughly ventilators, and we're aiming for 7,500 plus some, as you said. How many ventilators are currently under use for COVID-19 patients?
I think Professor Murphy mentioned the number before, but it was
50.
less than 50.
It was, I think
50.
it was 50.
Okay, so a fair bit of spare capacity to go then.
Yeah.
We're very pleased
that
to
was
be
at
in
the
this
peak.
position.
Yeah, great. Okay, thank you. That's enough from me. If there's any questions from Senator Davey, I'll defer to her.